Thank you. I'll be spending the next few minutes more focusing on how we achieve the goals of effective refractive error coverage. Just to recap, till a few years ago, maybe I don't remember the exact date, probably till a decade ago, all the assessment of visual impairment or blindness was based on best corrected visual acuity, which literally buried the recognition of refractive error as a cause. And I think that got rectified. And we have these huge numbers now of almost a billion people who have unaddressed refractive error correction. And then this is what prompted the goal that Andreas so described in detail about addressing the refractive error as a major challenge in eye care. And that gave birth to this global initiative called as SPECS. And then as he outlined, there's a lot of effort that's going into creating that ecosystem which will promote better services for refractive error correction globally in a very, very comprehensive way, looking at service delivery, the resources like people, awareness creation, making it affordable and monitoring. So as he mentioned, for the very first time, WHO has defined a threshold as to when we intervene for refractive error correction. And that's very, very important because it helps us define the denominator, and as well as they also defined, put a threshold for outcome of 612 or better, which helps us to determine or compute the effectiveness. As he showed in one of his slides, the overall coverage is around 43% globally, while the effective coverage, which means of those having the refractive correction, mostly glasses, some could be contacts and surgery, about 36% had a vision of 612 or better, what is called as the effective coverage. And the goal, as he mentioned, was to increase it by 40%. That means this 36% should become 76%. So that is the goal. And my talk is more about from a very practical perspective as to how we can achieve this. So one proposal I'm making is that recognizing that refractive error, with the exception of myopia that we talked about, is a condition that is neither preventable nor self-healing. So we have to intervene, which means it is in the hands of the providers to make a difference. So that's the first argument that I'm making. And the broad actions are about, one is enhancing access. That is, you get more people into the system, those who are not accessing care. And the other one is when they access the care, we make sure that everyone gets refracted, given the right prescription, and then they're enabled to get the glasses. Okay, and when we do this, we would achieve the target. And I want to give two examples of how this is possible. One is, I want to share with you some data that we did from a community survey recently. In the survey, we found that of the people who had refractive errors in a population-based survey, I'm not going into all the details, about 2,000 odd people had refractive errors, of which 680 were wearing glasses, which gave them the vision of 612 or better. Now, what we call as met need was 33%, and 65% of them were not wearing glasses. A small proportion were wearing glasses, which were not of the correct power. So if we are able to correct those wearing the wrong glasses, maybe even half of them, there'll be a marginal increase in the effectiveness. Will go from 33% to 34%. In the same survey, we also looked at the people who are not wearing glasses, 1,314, Of them, close to 300 people, 289, had actually gone to an eye care provider in the last 12 months. But for some reason, they were not refracted and given glasses. Okay, again, a provider's problem, which means that that entire group, if we were alert, we could have given glasses. And had we done that, then the coverage goes up from 34% to 49%. And then of the remaining, that is 1,314 minus 289, even if you cover just 50% of them, which will take some effort, but very doable, then the coverage goes up to 74%. More or less that 40% increase that is required. So we can very clearly see that achieving this is very much possible, even with the current system, only if you become more sensitive about these opportunities. And I also want to share similarly data from the hospital setting. So what we did was we took 1 day's outpatients from our hospital. We have a network of several hospitals and mission centers. And that particular day, we had examined 15,000 odd outpatients, of which a total of 3,200 plus had refractive errors, and of them, 1,590 were wearing the correct glasses. And then few of them were wearing inappropriate glasses. So the total coverage was 54%, with about 49% would be called as effective coverage. And then of those who needed intervention, that means their vision would have improved to 612 or better. For some reason, I don't know why, but we only prescribed glasses to only 35% of them, which means there's been a gap in our service delivery of about 65% not diagnosed or prescribed glasses. Of those who were prescribed glasses, 70% bought them, 30% did not. So there is a compliance gap of 30%. Again, addressable. So when we compute all of this at the end of the visit, that 48 or 49% became 61%. So there has been some improvement, but then this has been done without any special sensitivity or attention to addressing this problem. So I'm just showing a what-if condition. If we're able to close 50% of those gaps, that is, we are, instead of advising only 35%, let's say we advised 65, 70%. Or we are able to increase the compliance from 70% to 85%. Then the coverage goes up to 78%. So you can see that there's a lot that we can do as providers, and I believe that the entire effort or the ball is in our court. So some of the broad recommendations that we would like to make, or one, that we have a very clear protocol to make sure that everyone who will benefit from refractive correction actually gets the diagnosis under prescription. And today, in the era of digital medical records and all that, we can put alerts and checks and balances. And then having a checklist which will make sure that we're advising the right glasses to make sure that the quality is given. And we also have noticed that if you're able to give the glasses immediately, and if you had a good variety of choices, then the uptake increases quite a bit. I'll show you one particular example of that. And then to enhance the access, proactively doing screening in schools, workplaces, and we have got a lot of evidence. In fact, one of the landmark papers by Nathan did demonstrate that productivity jumps up phenomenally when you do workplace intervention, and then you recover the cost within a week's time or so. And of course, you need good documentation and continuous improvement. I'll conclude with this particular example. I don't know. Okay, I need to look here. So we did a study in outreach. When you do give only prescription, we found that only 25% of them ended up buying glasses or wearing glasses. But in the same outreach, like it's shown in the video, we're also able to dispense glasses on the spot. No, they choose the frame of their choice. You age and fit the glasses and give. The uptake goes up to 80%. It's the same kind of a population because it was a randomized controlled trial. No, but then the only difference was we're giving it right there, which means we completely eliminated the cost and effort of procurement. And that's a significant amount of money that is saved doing this. So I just want to once again conclude by saying that there is a lot that we can do without too much effort, I believe, to achieve the global target. Thank you.
Fantastic, Tulsi. Thanks very much for that. A lot of things to take away from that. I thought the idea that simply by making the glasses available at the time of outreach, you can get 80% of people to accept them. I think that's important. It is an important question as to whether they're going to continue to wear them. We know that's been a challenge. Unlike cataract surgery, in some ways glasses are the easiest intervention we do, right? I mean, it's easy. You can hand out the glasses. They're inexpensive. But unfortunately, unlike cataract surgery, once they're done, every day the decision has to be made to comply with them, and that is a challenge. I'm interested to ask you a question. India's been phenomenally successful in managing cataract surgery. You have cataract surgical rates that are approaching or exceeding those of European countries, and refractive error seems still to be a challenge. Looking at the special case of glasses after cataract surgery, how is that working at Aravind? What proportion of people are taking glasses? Is it, and I imagine you give them free for the free patients. Do you have a sense of what proportion of patients are walking away with glasses after cataract surgery? And do you look at all to see if those are worn down the line?
Yeah. So it's a pretty high proportion in the sense it's very much tied to having this follow-up mechanism. So the patients who come to the hospital get very detailed counseling about coming back. For those we go through the outreach, we go back to follow them up. So our overall follow-up rate is around 91%. And then integral to the follow-up is prescription giving glasses, where the patients seen in the outreach would get them for free under a scheme, and those who come to the hospital would buy whatever thing. And the uptake there again is very high. Prescription to uptake would be around 90–95%. And that's got to do with a lot with the counseling. Then they pay for it.
And that's the uptake of a prescription or the uptake of actual glasses?
Glasses.
The glasses.
Yeah, in fact, that 80% that we said was going back to the homes after 3 months to check who are wearing glasses.
Fantastic.
So I think there's got something to do about them paying for the glasses and continuing to use them. I think there is some correlation there. Yeah.
That ability to get glasses on and leverage India's huge success in delivering cataract surgery, glasses on after surgery, that seems like an important area to do and to make sure that every facility is doing as well as Aravind in that respect. Fantastic. That concludes the traditional sort of lecture part of our